critical care FCCM under able guidance of Dr. J.V. Peter and the Subramani, and who was well known people in the city, and he was more interested in neurocritical care and ICU and CMC Vellore. He has formulated guidelines, and after coming here with a lot of dedication and hard work, he is also DNB teacher in anesthesia and he is ICCM teacher. All his students are cleared the exams. He is 7 years working for last 12 years, and he's been got his name in the city with his commitment and dedication, and with the updating of the knowledge. And we are very associated for last few years for three reasons. One is we together conducted good conferences and good workshops. So this is our association in the city. So I welcome him to the group. So thank you, Mohan Rao, for coming and joining us. Thank you, and please take over the class.
Yes.
సార్ స్క్రీన్ షేర్ చేయండి.
చేస్తున్నాను. Good morning, everyone. Thank you, Mohan Maharaj and Dr. David and all of the rest of the Morton team for giving the opportunity. Thank you for inviting me and introducing me with kind words. Today's my topic is in the COVID-19. Meanwhile, I will give a little bit introduction before going to my screen is sharing now. So one of the, as you know, this intensive care is developing, and last 1.5 years we are facing so much problem with this COVID, and all over the world. The main aim is to. Are you able to see my screen, sir? Hello.
No, only your desktop is open. That this one, and topic is not open. టాపిక్ ఓపెన్ అవ్వలేదు సార్.
పొద్దు అన్నికి వస్తుందా?
దాని మీద డబుల్ క్లిక్ చేయి.
ఎస్ఎస్సి చేసుకోవచ్చు కదా
సార్. స్క్రీన్ మీకు ఓపెన్ అవుతుందా?
నాకు ఓపెన్ అవుతుంది.
మీరు దాని మీద స్క్రీన్ మీద పెట్టేసుకోండి. టాపిక్ ఓపెన్ చేసి ఆల్రెడీ
పెట్టాను.
ఇప్పుడు షేర్ చేయండి. ఇప్పుడు ఇది జూమ్ ఓపెన్ చేసి షేర్ చేయండి. ఇప్పుడు జూమ్ ఓపెన్ చేశారు సార్?
ఓపెన్ చేశాను.
ఇప్పుడు షేర్ నొక్కండి. స్టార్ట్ అవుతున్నట్టుంది. ఇప్పుడు డబుల్ క్లిక్ చేయండి దాని మీద.
చేస్తున్నాను సార్, చేస్తాను. ఓకే, యా. So one good thing is the learning for the ultrasound is very short. If you spend at least 24 to 48 hours, you can able to diagnose what are the abnormalities you can find in lung pathology. So that is one way of visible, sir.
No, not yet. మీకు వస్తుందా స్క్రీన్? అక్కడ
నాకు వస్తుంది.
There is some problem. Bashir is there?
సార్ ఆ పీపీటీ ఓపెన్ చేయండి సార్.
ఓపెన్ చేస్తుంది.
మళ్ళీ షేర్ స్క్రీన్ ఆఫ్ చేసి మళ్ళీ ఆన్ చేయండి సార్.
షేర్ స్క్రీన్ ఆఫ్ చేసేయండి.
Now is okay. I think it's coming. Now it will come. See?
Now it is coming.
స్లైడ్ షేర్ ఓపెన్ చేయండి. స్లైడ్ షో
లో పెట్టండి. Okay, go ahead.
So my today's topic is ultrasound in COVID-19 and how to interrupt. So main today's objectives for talk is how to discuss how to perform a systemic ultrasound not only in COVID, and identify the important what are the important sonographic signs in specific to the COVID-19 patients, and what are the few review relevant studies up to Kim, and what I want to explain the role of ultrasound in COVID-19 patient management. So coming to the introduction, as you know, last 1.5 year we are facing this pandemic, which is a global health challenge for us intensivists and every consultants. And meanwhile, this tool is very useful for assessment, follow-up, and aiding in clinical decision making. If we learn properly this ultrasound, especially in COVID-19, and it has a high sensitivity in detecting several pleural and parenchymal pathology, which is very, very specific to the this COVID-19. And the findings, ultrasound findings, small bit different from the bacterial pneumonia to the viral pneumonia. So, and these are the, if you compare straight away, we'll do the most of the centers that are doing the CT scan to prognostication and triaging and assessing the severity. So meanwhile, what researchers and they have compared the CT findings with the lung ultrasounds. So what we find some few findings in CT scan. Same thing, if you learn properly ultrasound, you can able to appreciate the findings like the thickened pleura and ground glass, and effusions are very less in compared to this ground glass in lung ultrasound. There's a B lines which are specific, and that is like a multifocal, discrete and confluent, and pulmonary infiltrating shadows, that is interstitial interlobar thickenings like a confluent V lines, subpleural consolidations, which is very, very characteristic to the viral pneumonias, and translobar consolidation, both non-translobar and translocar, and pleural effusions, and multilobar distribution, which is a very, very common in COVID-19. So these are about all the findings if you see in COVID-19. So before going into this, I wanted to put one question to the audience. Which of the following is less concomitant with COVID-19 pneumonia in an ultrasound chest? The bilateral option is A is bilateral symmetrical B lines, subpleural consolidations, patchy confluent B lines, and pleural effusions. Option E is A and D, and option F is B and C. Anyone can try? So before starting my lecture, this is the important thing in COVID-19.
Pleural effusion.
Pleural effusions less likely, and another one is it won't be symmetrical. It is a non-homogeneous. Bilateral symmetrical B lines you can't find in a COVID-19. So answer is A and D. Pleural effusions very less likely unless patient have associated COVID-19 with superadded severe bacterial infection, one cause. Otherwise, another metabolic abnormalities are a heart failure or a liver failure. And bilateral symmetrical B lines if you find in pulmonary edema only, cardiogenic pulmonary edema. So we can exclude when you use triaging, when your patient is presented initially to your emergency department. So coming to the lung ultrasound has high sensitivity for detecting pleural thickening and subpleural consolidation and ground glass opacification, which is equivalent to the CT scan. So when coming to the ultrasound COVID-19, you have to concentrate on, they focus mainly on the pleural surface and subpleural consolidations. So coming to the historically, if you look into the historically, the lungs are major hindrance for the use of ultrasound at thoracic level. This is the thought process before 2000s. that is especially 2015. So the lungs are not suitable for the ultrasound. This case statement is given the more famous book in 19 edition of 2015. But researchers, after the thorough knowledge kept in the ultrasound, they changed their thought process that in 20th edition, they have changed the word that ultrasound is often readily available and can help to rapidly diagnose few things like pneumothorax, pleural effusions, consolidations of lung parenchyma. With this, actually, point of care ultrasound importance came into the picture in our intensive care unit and triage centers and emergency centers. So, what are the advantages of lung ultrasound, in especially particularly to the COVID-19? It is very, very safer. Exposure to the radiation is very less, especially when we are wanted to do CT scan repeatedly. More and more people will expose, especially including healthcare professional. That is, we can come across with the point of ultrasound, and we can do repeatedly. We can do the morning, afternoon, night. If your intensivist is very versed with knowledge, good thorough knowledge in ultrasound, it is a low cost. It is very, very portable. We can move anywhere. And point of care, we can diagnose at the bedside itself, and it is very rapid and sensitive for pneumonia when is the patient have developed COVID-19 pneumonia. Coming to the principles of ultrasound, you as already stated out, air is enemy, major enemy for the flow for the lung ultrasound. The ultrasound waves won't penetrate so normal ultrasound cannot get through the air in the lung. So therefore, ultrasound bounce back almost 10%. With that, actually, because of bounce back, with that we are actually able to appreciate so many artifacts. With that artifacts, we are formed the blue protocol, rush protocol, and same thing principle is applied in diagnosing and diagnosing pneumonias and COVID-19 severities. So if you see when the patient having a normal lung, it is having a best aeration. When pathology like fluids, interstitial fluids, pneumonias, effusion starts, slowly this fluid contents air contents disappear and replaced with fluid. So when you are best aeration, you will see only the normal lung. When the loss of aeration is, we can see the so many artifacts like B lines, obliteration of the A lines, convulsant B lines, that too, and consolidations. So the same pattern you can appreciate in COVID-19 to assess the severity and resolution of the underlying COVID-19 pneumonia. So this is the lung air content. Based on this, you can able to see all these things. So coming to the in a normal patient, this is the normal CT scan chest. You can able to see the A lines. What is A lines? I will discuss. I will explain everything. So this is the, if you suppose patient is COVID positive, but lung is not involved, is CT scan is right side is showing, and left side is the ultrasound picture, ultrasound image. And if the patient slowly develop early COVID, like a patchy infiltrates, ground glass opacities, you can able to appreciate the same things without shifting to the CT scan like a B lens. So if it is intermediate COVID, when the patches goes to mild early pneumonias or a confluent, you can get the confluent B lens. You can differentiate. This is the early COVID simple B lens. This is the confluent B lens. The merging of the B lens you can able to appreciate. So when the patient developed severe COVID, so means almost replacing with the confluent means pneumonia, you can able to see irregularities of the pleura and some sort of subpleural consolidations and some sort of effusions also there. So this can able to see the pleura is irregular and not smooth, humpy, bumpy, what we can call it as, and some sort of pleural mild effusion localized and subpleural consolidation. So this is the somehow we can able to see the severe COVID. And stage comes severe, the complete loss of aeration. If you see patch means excellent lobar involvement consolidation, you can able to see the include the hepatized lung with air bronchoalveoli. So these are the complete loss of aeration with pneumonia. So these are the findings you see depends upon the stage of the COVID-19, early COVID, intermediate COVID, severe COVID, and complete loss of pneumonia cases. So when you are doing the lung ultrasound in COVID-19, how to do the exam? Before what to look for? What are the clinical integration and what are the pitfalls? So each and every process is having pitfalls. So I will discuss one by one. So as I told, lung ultrasound is evolving knowledge in COVID-19. So right now they are doing so many studies and to simplify to diagnose some more simplification and algorithms they wanted to give. So right now there is no clear data, no studies, and even randomized control studies. So what we are at present, we have an empirical approach and previous experience on different diseases like earlier ARDS, viral pneumonias, bacterial pneumonias. Based on that data, they have aggregated and given some protocols, algorithms to do the lung ultrasound in COVID-19. So as you know, coming to the probe, we can use the both linear low frequency convex probe, which is most universally used probe for diagnosing pneumonia. Especially if you low frequency, you can able to appreciate the effusions and central lobar consolidations, and because penetration is high. And for pleural pathology and subpleural consolidation, you have to choose and a good one is the linear probe, that is high frequency, which is better to visualize subpleural spaces, which is more characteristic findings we see in early stage of COVID-19. So as I told that it is developing now, they have introduced a microconvex probe, which is we can adjust the frequency, low frequency, high frequency, depends upon what we are looking for. I don't know in India it came or not. So with a single probe, we can able to appreciate we can change the frequency of the probe. So no need to change the high frequency probe, low frequency probe. That is a microconvex probe it came. So when coming to the settings, pre-settings, so most of the ultrasound machines have abdomen preset. So nowadays newer machines, they are coming lung preset. So you have to select the lung preset if available. If it is not available, go for abdomen and scan for at least one complete respiratory cycles. Meanwhile, when you are observing the lung scan, you have to switch out the tissue harmonics, compoundings, and filters. These things also you have to off to increase the image quality. And coming to the settings of the depth, usually you have needs 8 to 10 centimeters depth to see the entire as far as deeper it gives a deeper penetration and depth of the consolidation areas. So usually 8 to 10 centimeters is needed. In a lean patients, you can adjust for 6 to 8 centimeters, higher for the obese patients. And another thing is when you are going and we are concentrating ultrasound chest, you have to adjust the gain in order to optimize the visualization of the pleural line. One of the important thing when you are whenever you're doing the ultrasound chest, you have to observe the movements and everything of the pleural line. So according to that, you have to adjust the gain. So next is how to put the probe. So what is the traditional way? Traditional way of teaching is together is we have to put the probe horizontally, that is vertically, that sagittal way of longitudinal scanning. It gives a bat wing appearance, but each also produces artifacts, hinders our image by in between. We have to two ribs will be there. That is why as you are learning more and more air experience, you can turn the probe to the horizontal, that oblique, it gives a more picture and less interference, because of we can avoid the this rib shadows in between. So you can put horizontal way or a oblique scanning. The main aim when you are doing the lung ultrasound, you have to appreciate clearly the pleural line. So focus on the pleural line. This is very important. So we don't know. Yeah, I told we don't know the adducts movement, which is the best scanning approach in COVID-19. So many approaches came, and individual people are giving their approach. One way is means four quadrant approach came, 6 quadrant, 8 quadrant, 12 quadrant. According to your feasibility, you can do. And traditionally, what is, you have to draw the one parasternal line, one anterior axillary line, one posterior axillary line, and posteriorly also one line across the paravertebral line and linea scapularis, and one horizontal line. So there are 4 or 8 upper segments, 8 lower segments. So it is totally gives us around 16. And also you can do the 12 segments approach, 6 segment approach, whatever it may be feasible. In the COVID, particularly COVID-19 comes, especially in early stages, you have to examine the all quadrants, because the COVID-19 involves both bilaterally in both upper lobe, lower lobe, though it is predominant and right lower lobe and left lower lobe and posterior aspects. But to triage and prognostication, you have to see the all the segments, because it is a patchy distribution. So this is the another thing, scanning scheme. You have to draw one line parasternally. One is anterior axillary, and one is posterior axillary, and one is horizontal line. Depends upon that. But when you are doing, you have to keep your mind that which lobe or which segment we are doing the scanning. So that is why new way of moving the probe in a chest wall came. That is a lawnmower's technique. In this, what he is done is he is keeping the probe in horizontal or oblique. Is moving the from top to bottom in this way. So from transversely from up and down, like that up to here. You can go for like that also. This is for the anterior chest. This is the for the lateral part of the chest, up to down. So in between the ribs, to visualize and to avoid the missing something. In posterior, especially scapula comes very the interface while you're doing the ultrasound chest. That is where between the interscapular region below the scapula, you can go through the this way. So this is called lawnmower technique of doing the ultrasound chest. So another way is quick way of assessing the diagnosing the doing the ultrasound, doing the pathology is like in stain flaps point. It is together people are doing. Just to some few people passionate to keep the directly to the probe and posterior axillary line. This is called flaps point. So posterior lateral alveolar pleural syndrome. Through this, we can immediately diagnose whether this patient having consolidation or pleural fluid. So if it is posterior lateral alveolar pleural syndrome, if it is positive consolidation, and if we need to know consolidation or no pleural fluid, it is anaerobic fluid. If you find, you can immediately diagnose it is a pleural fluid. So keeping that directly, because most of the lung pathology start in the basal area. So by keeping this in mind, they have immediately identified and given a lichen stain flaps point. You immediately can diagnose patient having a pneumonia or a pleural effusion, or it's having a non-lung pathology. So next is what to look for. One is finished how to do the exam, quadrants and lawnmower technique and flaps point, the lichen stain flaps point. So what to look for? So actually, I like this slide. Actually, this is a slide is given the anatomy with sonoanatomy. So when you are keeping the probe, when placing the probe at the anterior chest wall, whether it is a sagittal or oblique, whatever it may be, you find the skin and soft tissue and pectoralis muscle in between intercostal muscles, so with the two ribs. So this is the ultrasound image picture. So this is the immediately below the intercostal muscles, you within the 1 to 2 centimeter below, you find hyperechoic line. That is the pleural line. That is the pleural line. So you find this is a very important thing to have to notice. And below that, lung line. So this is the anatomy. This is the sono anatomy. So based on this, actually they have given a score like 0 point, 1 point, 2.3 points. So when to grade the severity, when you are no point, normal aeration, no B lines, multiple B lines when is 1 point, multiple coalescent B lines when the B lines merge with each other and produces multiple B lines. This is called, it is a 2 points, and for consolidation they allocated 3 points. That is complete loss of aeration. So normal aeration to deaerations. So this is the progressive pattern of the diseases in case of viral pneumonias. So this is the image, that is the, you can see video. This is how the pleura moves. This is just 1 to 5 centimeters below the rib. It is the moving with the inspiration expiration. So what we have to see, observe is whether it is sliding and what is the nature of the this pleural line, means it is whether it's thickening or there smooth or irregularities, is there any subpleural consolidations. Subpleural consolidations. So this is the way where this is the reason why we'll get the lung sliding when you keep the probe over the chest. Because of lung, it moves with inspiration expiration, the pleura moves in the opposite direction. It gives us lung slide. See how it is moves. This is the first and foremost when you are doing the ultrasound learning chest. You have to appreciate the smooth the pleural line with sliding. Yeah, we can able to. So with this, we can move to the other A lines, which are the normal in a case of a fully aerated lung. So when the normal ultrasound, which cannot get through the air lung, therefore ultrasound bounce back. So these are called the reverberation artifacts. The ultrasound waves revert back to the ultrasound probe. With this the pleural produces the reverberated. So these reflections of pleural called the A lines. So these are the classical reverberation artifacts because of pleural line. The ultrasound waves reverberates back to the ultrasound probe, and these are bright horizontal lines deep to the pleura in a equal distance you can able to find. This is means if you find A lines, means this is a lung is absolutely normal. To appreciate this, you have to use the low frequency probe, that is a curvilinear probe. So these are the A lines. So you can able to see the pleural reverberation artifacts in a equal distance. These are the rib shadows. Again. So coming to the B lines, these are the pathological lines. When there is the fluid, that is means actually that the reverberation artifacts of these artifacts is whatever we are seeing based on the composition. If it's more water, less air, or more water. The composition. So when more water is replaced with air, you can see the reverberation artifacts inside the alveolar produces, and this B lines, when this reflection of pleura will be gone when the patient's having the alveolar is replaced the air with the water. So these are the sound becomes a bounce in between alveolar instead of pleura. the multiple bouncing of sound between wet alveolar. These are called the B lines. So these are the B lines. What they can be called as the comet tails or rockets. These are the laser-like vertical hyperechoic reverberation artifacts. Originates from the pleural line, obliterates the B-A lines. That is the important things. Once a B lines comes, A lines goes and moves with the lung sliding. That is another important. When you are able to appreciate the B lines, you have to see the lung sliding. And normal the B lines less than 2 in fields is normal. If this see multiple B lines more than 2 fields, it is called it is a pathological. So see these are the bit confluent B lines. You can able to appreciate the pleura and moving with inspiration expiration. Another thing is it starts from the pleura and extends up to the base of the screen. So in compared with jet lines, other lines in between, you can able to see that this ends before the baseline. So these B lines is common pathological, earliest one of the earliest sign in diagnosing COVID-19 pneumonia. So these are called the racket, jet racket, flash like comes. So these are the A line. When you put the slides, how to compare the A lines with B lines. A line horizontal lines and B lines is the confluent B lines, which starts from the pleura and extend to the B lines. So once the B lines appearance happens, the A lines disappears. And C is the consolidations. Once the patient progresses and produces this completely alveoli filled with the inflammatory fluid, this produces the consolidations. Like hepatitis liver. In between, you can be able to see the small A and alveolar, and you can able to see. So see, this is the good image. You can able to see the how with inspiration expiration alveolar is opening, entire that lung is consolidated. Skin able to see the small effusions, and the pleura will be shaded. Yeah. So different areas you can able to see the lung is coming in between consolidations, and the pleural is a shred like, not as a tissue paper. So these are the normal ultrasound way you will get in a COVID-19. Whether you can get the A lines in a normal early stages, B lines in when that patient is if he develops ground glass opacities, and which is extended to the extends to ground glass apertures, you can be able to see convalescent B lines. When this patient is means lands into pneumonia, you can able to see the lung consolidations. So, but one important thing you have to remember is don't consider only the degree of deaeration, but also the qualitative pattern and distribution of alterations is very, very important when you are doing the ultrasound for the COVID. So another thing is important from the other pneumonias and bacterial pneumonias, you can able to the spared areas. So here is the consolidation, here is the entirely normal. One of the characteristic feature is seen in COVID-19. So spared areas and white lung. So that is why in COVID-19 you have to try to examine all the quadrants of the chest. So what are the important characteristic findings in COVID-19 is what in the pleural thickening. You can able to see the pleural thickening, irregularities, discontinuous, humpy, bumpy, and pleural lines, simple pleural lines to confluent pleural line, discrete, bilaterally non-homogeneous B lines, and pleural irregularities, subpleural consolidations, especially in early stages. So first is pleural thickening, some sort of B lines, later is subpleural consolidation, and in the next stage it moves to the, as progress it is going to the consolidations. So coming to the, with this findings, I wanted to put one case. This is a 40-year-old hospitalized with fever and cough. Saturation is 98 at the room air. There is no tachypnea, lymphopenia. So is ultrasound, when you did ultrasound, you able to see some zones. Some zones, B lines are there. B lines appearance is there, but in anterior. For the same patient, we did the CT chest. See here, you can able to see. This is the anterior portion is entirely normal. So by it is correlating with our ultrasound picture of simply normal pleura with A lines, no B lines in this also. When it comes to the posterior aspect, so you can able to see some sort of B lines starting. This is the early stage. So after 4 days, patient suddenly deteriorated and he went into respiratory distress and a very high temperature. Ultrasound abdomen is done. Repeated, it is significantly worsened. So yeah, you can see in anterior also some B lines appearing. Pleura is mildly thickening, here is smooth, but here is you can able to see some subpleural consolidations. Here also pleura is irregular, thickened, not smooth, some sort of pleural consolidations, subpleural consolidation. So compared to E, this is the when the patient is admitted, this ultrasound. When patient is worsened, you can able to see the thing. For the same patient, we did the CT chest. You can appreciate the finding CT chest. Patchy consolidations are increasing. Okay. So this is the beauty of if you learn properly ultrasound, if you apply your findings to the thing. So another thing is, so what famous that our Gatonini has given L type and H type. You can some extent you can able to differentiate which is L type and H type, because after intubation only you can able to differentiate L type and H type. In L type and H type, whatever the type you have, patient having hypoxemia. In this, most of the thing is aerated, very less consolidations. Same thing you can able to see the simple B lines. When the patient H type comes, you can able to see the consolidations, thick confluent B lines. So if you use properly the ultrasound, you can able to differentiate which is L type and which is H type. Some extent the researchers are doing it, is in a development process. So coming to our clinical case, they did high flow nasal cannula, autopronation, steroids, antiviral therapy, immediately self-proning. Self-proning also, whether patient is improving or not, we can able to appreciate by doing the ultrasound. So more inhalations. So coming to clinical integration. So it is evolving. It is a very good role in diagnosing in COVID-19, especially it is more sensitive than chest X-ray. In chest X-ray, we can't able to appreciate early changes, sure, unless patient develop consolidation, ground glass opacities, we cannot able to appreciate through a chest X-ray. And usefully in trials in Western countries and European countries, they have developed protocols, algorithms are given to the emergency physicians how to triage the ultrasound when patient is sent RT-PCR and blood investigations. And role in risk stratification is plays very important for short-term prognosis and high negative predictive value. If it is lung is normal, you can prognosticate good prognosis. And lung ultrasound changes are earlier than clinical iteration. So for this, repeatability is very, very important. According to that, also you can take the strategies to prevent the clinical iteration. And it is very good role in monitoring and titrating treatment. And I can also see the how it is responding to the drugs like steroids, antivirals, and monitoring the respiratory support, and choosing the patient's position when patient needs supine position or prone position. And it is very useful in timing of weaning also. So always consider a distance from the symptoms onset, that is in the length of stay, length of day of disease. And always integrate the ultrasound findings with the overall picture and other tests. what are the pitfalls? If you look into what are the pitfalls with ultrasound, it is purely operator dependent. That is where you have to improve your skills of doing the ultrasound just regularly, and also patient dependent. Even you obese patient, I'm sure it is very difficult to appreciate all the findings, and you have to scan all the chest, especially COVID-19, because it is presents like a patchy pattern. You miss if you do anterior part, and if you miss, you won't do the posterior part. And another thing is risk of spread of infection is there, always there, and that is why you have to dedicate one mission to the COVID ICU. And another thing is it is not suitable detect a centrally located consolidation, especially which we'll see with bacterial superinfections, and also unable to distinguish chronicity of the lesions. If suppose patient having a pulmonary fibrosis, COPD, it is very difficult to differentiate, and also degree of airway obstruction. These are the few pitfalls, but we can, if you learn more properly and regularly, thoroughly, you to some extent come across the few pitfalls. So coming to studies, as COVID-19 outbreak comes, we throw away the stethoscopes. That is a stethoscope and more ultrasound. You can able to appreciate the B lines and C lines. And if you look into another paper again, finding of ultrasonography of novel coronavirus pneumonia during 2019 to 20 epidemic. So this is what I told. COVID-19 is a foci are mainly observed in the posterior fields in both lungs, especially in the lower fields. And there will be focused B lines and waterfall signs are visible under the pleura. These B lines are fixed. These one interesting characteristic feature, these B lines are very fixed because the ground glass opacities and mild infiltrates. And pleural line is unsmooth, discontinuous, and interrupted. And you can able to see the subpleural lesions, which is a patchy, stripped, and nodular consolidations. Air bronchogram sign can be seen in the consolidation in later stages. The involved interstitial tissue have a localized thickening and edema. There is a maybe local effusions around the lesions. There is a localized effusions only. You won't see the massive pleural effusions. And CDFC and color Doppler ultrasound shows insufficient blood flow supply to the lesions. Rarely we do. High frequency linear array probe is suggested to use for assessing the minor subpleural patches information. So coming to this thing, it's a summary was an excellent tool to assess the for complications in patient with poor deterrence. So these are the characteristic features. What I told is the pertaining to the COVID-19. But when you are intubating, ventilating a patient, when the patient is prolonged in the ICU stay, you can expect some complications. That complications are also you can able to diagnose, like patient if you detect suddenly, you can have to diagnose. You have to rule out the pneumothorax, heart failure, new infections, and new pleural effusions. So this tool also another way also very useful. So another clinical case too. This is a 32-year-old male patient, fit well, SOB, high-grade fever, dry cough for 3 days. Saturation is 90% and FiO to 100. Is having a high DDMS, high markers, failed NAV, straight away intubated and connected to the ventilator. Immediately before shifting to the CT scan, this emergency physician has did ultrasound chest in all areas. You can able to see the anterior part confluent B lines, subpleural consolidations, means pneumonia, including with air bronchogram. So this patient intubated and did recruitment maneuvers. And this also, when you are intubated and then this ultrasound chest is useful for monitor for the recruitment and response to proning, help weaning from the mechanical ventilation. And there is a strong correlation with the CT scan also. The earlier detection of the subpleural pathologies, that is the X-ray. So another clinical better is triage, already told, risk stratification, we can give prognostication and also assess the disease progression. So this is the algorithm intensive society of critical care people have given, especially to the ultrasound chest in an emergency room. If any patient comes with COVID-19, you place the probe in linear probe at 2 points, one on anterior chest bilaterally, and place your curvilinear probe at plaques point. This is a quick way of doing the ultrasound. If you find A lines and normal flaps, so normal, no need for any intervention. If you find the abnormal like B lines and consolidation abnormal, then identify pattern. The pattern 1 and pattern 2. So pattern 1 is if you find the diffuse B lines, this patient, you think that if you patient may respond for PEEP. If you pattern found the consolidation atelectasis, these patients may respond to quickly respond to the prone ventilation. So this is one of the algorithm given. So the way of planning the protocols. This is the diagnosis. So A pattern, that means pattern A, diffuse B lines, PEEP response to, and consolidation, you straight away put them into prone ventilations. Another reason, when you are doing the progression of the disease assessing, if the patient is progress from diffuse B lines to consolidations, it is the disease is progressing. Same way, when you are resolving the ARDs, means in COVID-19, it is focal B lines to A lines.
Sir, he had another program. He wants Zoom.
Okay, one last slide.
Okay, sir. Thank you.
So this is the apart from the COVID, I put this thing. If any patient comes with ARDS and pulmonary edema, it is very, very difficult to differentiate by seeing the chest X-ray and also but the CT scan. In the radiologist also, it is very unable to differentiate unless they will have a proper history. So if you well versed with pulmonary, means lung ultrasound, you can differentiate some extent. In ARDS, you can find the anterior consolidation. Pulmonary edema, no consolidation itself. In ARDS, no lung sliding present. In pulmonary edema, lung sliding present. And ARDS, the B lines are spared areas and in between non-homogeneous distribution. In pulmonary edema, diffuse and relatively homogeneous distribution will be there. And there will be pleural abnormalities in ARDS. In pulmonary edema, it is thin, smooth line, no pleural abnormalities. Some extent you can differentiate at a point of care ultrasound by using this. So this is the blue protocol, as you all know. So the probe cannot replace your brain. You have to think about your knowledge and clinical judgment is very important. So thank you, sir. Thank you so much, Dr. Mohan Maharaj, entire Motan team, and Dr. David. I will be happy.
You, sir. Yeah, very good, excellent presentation, sir. And you made very simple and very clear about the ultrasound in COVID. I think people are using to start on bedside for get benefited by this class. So thank you very much, sir. Because lack of time, we are unable to take the questions because that Bashir has to start another program.
Next week,
thank you all, sir. Thank you, sir. Chappan, sir.
Next week, sir.
Okay, sir. We will, next class.
Thank you, Mohan.
Thank you, Mohan.
Thank you, sir. Thank you.
Yeah, thank you all for your appreciation.
Thank you all. Thank you, Mohan sir, Mohan Rao.
Thank you, sir. Thank you.